Mark Doherty, the hospital epidemiologist at Baptist Hospital Lexington. Welcome to our next COVID-19 update. This is, I think, number 6 that Dr. Rodrigue has given. Well, the saga of COVID-19 continues. We were hoping that we would get a little break here over the summer since it's not respiratory virus season, but it didn't happen. And the epidemic marches on. We're continuing to see more cases in Kentucky, more cases in Lexington. We're actually at our peak here at Baptist Hospital Lexington, and we're trying to gird ourselves for the fall here and the respiratory virus season. There's several things that Dr. Rodrigue is going to discuss in the update. One of them is therapeutics and the controversy of use of tocilizumab. Another one is DVT prophylaxis. And then one of the more important ones is the new CDC criteria for time-based discontinuation of precautions for COVID-19. Dan, thank you for all the time and effort that you put into this. And here's Dr. Rodrigue.
Thank you, Mark. Let's begin. What we're trying to cover today is an update on the epidemiology, some selected clinical aspects and therapeutics, and then prevention aspects of COVID-19. I was thinking back that this is now the 3rd pandemic that I've been involved with, and people could say, does that mean I was involved in the 1918 epidemic? And the answer is no. But 3 pandemics that I was involved with, and maybe some of you out there were, is that one is the HIV epidemic, the second was the 2009 swine flu pandemic, and then COVID-19. When you look at these numbers, it's just a steady march toward more people infected and more deaths, and it kind of gets to be blurry after a while. People are, one day it's 20 million, the next day it's up by X number of 100,000, and it's difficult to wrap our hands around this. Remember that this outbreak has started probably around December, and here we are 8 months into it, and it's still ongoing. I mean, we did have some hope at some point that maybe the summer months would change this, but I think we have to recognize that this is a new illness and that it is continuing to grow. So some of these slides, by the way, all these will be available on the Baptist site, so you don't need to scribble down some of these messages. If you need access, you can ask the Baptist and they'll be able to get you these slides. The infection fatality rate is now at about 1%. Remember when we started, we said it was close to 3% with the initial numbers, but over time, as we expected, your infection fatality rate goes down as you diagnose people with less severe disease. Initially in most outbreaks, you focus on the severe disease, and so it looks like everything's a lot worse, and over time, you recognize that there's a spectrum of illness. The risk factors haven't changed much. Still age and the comorbidities such as obesity, COPD, diabetes, et cetera, those things have remained about the same. The incubation rate and incubation has remained about the same as well. Most people get sick within 2 to 5 days, but the range has been 2 to 14 days. There are still more data coming out regarding the disproportionate number of cases based on race and gender, and perhaps even blood type O being more susceptible to illness than blood type A. Most people that are hospitalized have a risk factor. And if you're looking at children and their illness, most of those children also have common comorbidities, including obesity, neurologic diseases, and asthma. Here's something interesting. Over the course of the outbreak between March and July, the case fatality rate, the mortality over time has been decreasing. So is the illness changing, or are we getting better at treating it? Even if you break that down by age group, starting off in March, the case fatality rate for somebody 80 years old was much higher, and it's going down fairly dramatically over time. Over the last 7 days, if you look at the spread of who's hotter than colder, the darker areas being the hot areas, is still the Americas tend to be the area where the outbreak continues to accelerate and is still ongoing. Africa, I think, probably lags behind in terms of reporting cases, and you still have a significant amount of disease going on in Russia. The primary transmission route remains to be respiratory droplets, probably from close contact, and to a lesser degree, contaminated surfaces. And there's been a lot more publicity over aerosol being a route of transmission. Aerosol transmission at this time is still primarily related to procedures and probably crowded areas and poorly ventilated spaces. But the overall proportion of cases related to aerosol transmission is still relatively low. There is no good evidence or widespread evidence of transmission of COVID by breast milk or vertical transmission to newborns. Most of the newborn cases have been reported are thought to be related to droplet contact from mother to baby. How do we put some of this information together? Say we had that article published on SARS being found on door handles, cell phones. If you go into patients' rooms, you can find it on surfaces. There were laboratory data reported on, how long did SARS remain on surfaces. But at this point, it's still not well known how significant any of these fomites are. So describing these findings in the lab doesn't always transfer to their importance in transmission. We learned earlier, within the first couple of months, that pre-symptomatic and asymptomatic transmission were relatively important, that 48 to 62% of transmission may occur actually in the pre-symptomatic stage, which again made control of the outbreak very difficult. This was in contrast to previous SARS and MERS outbreaks where most of the transmission occurred after you were symptomatic. This is a contagious virus. It's more contagious than Ebola and the flu. One SARS person infects 2 to 3 people, but it is not similar to measles transmission in terms of 12 to 18 people, which is our classic aerosol transmission. So let's touch on airborne and aerosol transmission because that's gotten some publicity and some concern because it does relate to what we're doing for prevention. Are we supposed to all be using N95 masks? Will surgical masks be appropriate? And so what are the data supporting possible airborne transmission? The teaching has generally been droplets are larger particles, greater than 5 microns, that drop to the ground within 3 to 6 feet of a source infected person. Aerosols are smaller, and they evaporate in the air, and they can leave droplet nuclei that are small enough to remain suspended in the air, potentially for hours. So we have experimental data supporting the possibility that COVID may be transmitted by aerosols, going into a lab, generating aerosols, and finding virus. But remember, it's more complicated than just looking at a laboratory experiment. We have to take all this data in context and try to put it toward this outbreak. Infection not only relates to the route of exposure, but also the size of the inoculum, the duration of exposure, and your host defenses. So what data would support aerosol transmission or airborne transmission? We have experimental data that we can generate aerosols of COVID. We have some clusters of outbreaks related to choir participants, restaurant patrons, office workers who share closed spaces with poor ventilation. Although we don't have full data whether other exposures might have contributed to those patients developing infection. There's a recent University of Florida study that came out within the last month that demonstrated live virus could be detected 7 to 16 feet from a patient, although it was in a low number, and it's unclear whether or not this live virus was enough to cause infection. Factors that kind of argue against widespread airborne transmission is that what we are observing, and then we have 20 million cases around the world, is that still the reproductive number, the number that we think about in terms of contagiousness of COVID, is still relatively 2 to 3 people get infected, which is a lot different than our typical airborne virus, such as measles, where you're going to infect 12 to 18 people. Most people that are infected with COVID, oftentimes, and we mentioned this previously, 50 to 60% of those people are infectious with high viral loads prior to even being symptomatic. They have a lot of opportunity to transmit, if they had airborne transmission, to crowds and personal contacts with most people in a 7-day period. But we're not seeing that. So we're not seeing these explosive transmission that would indicate it's more aerosol than droplet. If you look at other data and putting that in the context, the secondary attack rate is about 5% of contacts. And if you're living in a house, it's about 10 to 40%, which is a lot different than, say, measles, which is the traditional airborne virus. So if you have a bunch of susceptible people within a household, with one person getting sick with measles, 90% of those people tend to get infected. So that really doesn't match typical airborne transmission as a major route. Close but less sustained contact, for example, sharing a meal with somebody, gives you an infection rate, secondary infection rate of about 7%. If you're passing somebody along the mall who might be infected, your secondary attack rate is about 0.6%. If you're looking at healthcare workers who are exposed to a patient while wearing a face mask or no PPE, the attack rate is less than 3%. So these things would suggest that the major method of transmission is still droplet, and you have to be in a relatively close contact. That doesn't mean that aerosol transmission can't occur. Of course it can occur, especially, and there are guidelines focused on that, especially when we're generating aerosols with high-risk procedures, intubation and CPR. How does this compare to other pandemics at this point? Swine flu in 2009 estimated to have infected about a quarter of the world's population and killed maybe 500,000 people. In the US, there were 61 million cases, 275 hospitalizations, and 12,000 deaths. But the case fatality rate was very low. And it was a fairly widespread virus, but it didn't kill a lot of people. The Spanish flu is the benchmark for terrible outbreaks. It infected about a third of the world's population. Remember, in 1918, there weren't as many people in the world, and a third of the world's population now would be billions. 50 million deaths, 675,000 deaths in the US. The Spanish flu outbreak, however, took about 2 years. We're only 8 months into this outbreak. So we're probably going to land somewhere between these two. We probably continue to have mounting cases, whereas we only have 20 million worldwide. I think in the end, we might have 100 million, 200 million. It wouldn't be a surprise with a lot more mortality going on. The beginning of the outbreak gave us a clue. We didn't really make huge policy decisions on this, but asymptomatic transmission is an important part in this. The initial outbreak that was reported in Seattle showed us that about half those people in the nursing home were asymptomatic. And we took that data along with recognizing that a significant portion of people were having high viral loads at the beginning of their illness before being sick, making them more contagious, to kind of move forward with masking recommendations. So where are we at now? As states are reopening, we are having a resurgence of disease. And it is primarily in this southern part of the map. If you're talking about areas 9, 6, and 4, which encompass the Southwest, the Southeast, and Texas, and those areas are having a surge of cases. Here's more data showing us what we're talking about in terms of how we're trying to fashion policy. Choir practice, where one person that was symptomatic infected a significant portion, over 80% of the people that they were in contact during that choir practice. But if you wore a mask in this hair salon, so these two stylists were wearing a mask and taking care of 67 people. And again, if you're in a hair parlor, if you're a barbershop, for me, it takes about 1 minute. But if you're in a regular barbershop and take a lot of time, you get a significant exposure. But nobody became infected because these two hairstylists were wearing a mask, kind of supporting the recommendations for masking. If you look at masking and how we have affected the outbreak, this is a graph showing that over time, this is based on number of days of the mandates being placed, looking at states, the rates of infection went down depending upon how long you were having that mask mandate in state. This is a mandate for everyone to wear masks. If you just focused on employees to wear masks, however, you didn't have much of an effect over time. The outbreak still has, we're thinking about going forward, what we're going to do with schools, and people have a real reliance on testing, and that testing will save us. Here's something saying, well, not so much. Here's a camp where everybody got tested before going to camp, so you would think that you would be safe. But within 1 week, 44% of the people attending that camp in Georgia became infected, and the camp had to be closed. So in terms of thinking about schools or long-term processes, one test is really not going to guarantee you success. None of these people were masked because, again, part of the policy was you got tested. If you were negative, you didn't need to wear a mask. The pandemic has collided with other issues that go along in the world. This is really not a surprise. We have poverty, we have social inequities, we have chronic illnesses in the country that have intersected with a contagious illness and have caused outcomes related to those pre-existing conditions. So wherever something lands, it will affect and destabilize whatever else is going on. So in Africa, if you're talking about taking care of HIV, TB, vaccination, measles, all those things tend to be affected because COVID itself starts to destabilize and focusing on COVID. If you talk about the United States, COVID lands in a country that still is having some issues with chronic comorbidities like obesity, hypertension, diabetes, and has caused its secondary outcome. Initially, our outbreak was focused on, it started at a nursing home, which really should have been a red flag that nursing homes were going to be an issue. It's amazing how things work out in outbreaks. The first outbreak reported was in a nursing home. That was a red flag. Now, within months, all of a sudden, it's a common story. It lands in an area of really high susceptible patients, and it spreads like wildfire and decimates the nursing home population, and also the healthcare workers involved with taking care of those patients. So the first wave of infection started in those nursing homes, spread to the community, with the other wave starting to spread with widespread, by March, widespread community transmission in cities, especially with large population densities like New York City. All states were involved by the middle of March. Then you have areas that had, again, the right circumstance of infected persons and the way the business was set up. And that might be the service industry, day laborers, food service industry, prison systems, et cetera. And then this currently, as we start to reopen restrictions in states, because again, remember that the initial focus for a lot of the restrictions and shutdown was to build capacity, to build PPE and supply chains, and that has occurred. But then as we relax, some of the transmission has increased in states. And it doesn't increase the same in every state. Healthcare workers have been part of the outbreak but data has been slow to be obtained. We don't obtain in every state, healthcare worker status isn't always obtained. So amongst the most up-to-date data, amongst 800,000 cases or so reported to CDC where we have healthcare status reported, 130,000 healthcare workers, of which 600 of those have died. Local hospital systems, if you're talking about Baptists, we might have in the order of the whole Baptist system, about 50 some odd healthcare workers involved, of which the majority of those, when we look into it, have had community exposure as their risk factor and not patient exposure in terms of how they acquired their illness. So opportunities for exposure in the workplace do exist, however, and we have had some exposures related to unsuspecting COVID positive patients. So asymptomatic patients that might come into your system or never got tested and then became exposed to other people. All this type of data is being used to fashion policy, for example, moving forward with testing all patients as they get admitted. And then getting infected from a coworker is still possible, especially if you're not using a mask and congregating in an area like your eating areas. So risk factors in studies that look at healthcare worker exposures have reported suboptimal infection control practices, not hand washing, not using your PPE correctly, and also, again, community exposure. If you had a positive family member, you're more likely to have become infected as a healthcare worker. And there are data showing that if you use PPE correctly, that shows you have protection against getting infected. If you look at seroprevalence studies, not a lot of this is surprising. I mean, here's New York City, where along the star you read here, this was one point of time looking at 40,000 healthcare workers in New York City that 14% of them have evidence of being infected. If you look at first responders like your EMTs, about 10% of these Florida EMTs were infected, showing evidence of infection by serology. And interestingly enough, the ones that were positive for COVID and none of those people got vaccinated for routine preventative vaccinations, such as influenza. Now, the reason that's important is that there are pre-existing data showing that your risk tolerance in terms of your likelihood for believing that some of these infections, you're at risk for some of these infections, you don't tend to believe it maybe if you don't want to get any vaccinations because you think you're basically, you're bulletproof, and you're not. Those people that don't get any vaccinations, their behavior is correlated with higher risk behaviors and decreased use of PPE. In the US, we have over 5 million cases. This data will always change, 162,000 deaths. Again, that data is probably outdated already by a couple of days. Our first case was reported in February. And if you look across the country, it's not a simultaneous outbreak. So what occurred in New York City really didn't occur in Texas until later when they opened up, or didn't occur in Arizona at the same time. So things really will depend upon local conditions. This still holds true that the older you are, the more likely you were to experience death, especially if you were over 65. The majority of deaths in Kentucky are in those that are nursing homes and elderly. And if you look at hospitalizations, we recognize that non-Hispanic Blacks and Hispanics tend to have a higher hospitalization rate for a variety of reasons that are being still determined. Is it comorbidities? Is it living circumstances in terms of population density? Those things are being discussed. And while we talk about morbidity, remember that regardless of your age range, you may not die, but still you will get hospitalized, and a significant proportion of even younger people will have needs for oxygen supplementation because they get sick. 9% of 35 million tests are positive to date. This range has gone up and gone down depending upon what time period you're looking at. When we completely shut down the country, the rate was a little lower. Then as we opened up the country, the rate starts to creep up again. Most of the hospitalizations occurring in the elderly and those with comorbidities. Seroprevalence, if you look across the country, still, however, despite, you would think with all the publicity that you get that maybe, 90% of everybody should have been infected by now, because it always seems it's incessant. Every time you turn on the television, it's 24/7 cable saying, it's just ongoing and relentless. But still, when you go back into communities, seroprevalence is fairly low. It's still probably less than 5% in the majority of the country. If you look at before and after in some select cities between March and June, if you started just at New York City on the left-hand side in March, their seroprevalence rate was around 6%. But if you repeated that study back in April, all of a sudden it's up over 20% in New York City. If you look at the rest of the state, however, it's about 3%. So it's not simultaneous. The curve started to go up around July for the country, and now it's maybe slowly tracking down. With the 7-day average, you can see that the cumulative outbreak still affecting widespread across the country. If you look at Kentucky in particular, we tend to stand out as not having as much of an issue. And if you're focusing just on Kentucky, we have had a fairly flat rate come July, but you can see that between, after the middle of June, we're starting to peak again because of the relaxation of some of the guidelines and probably some of the personal risk assessment that Kentuckians have. You can see that it's fairly widespread in Kentucky with concentrations in the eastern part, central part, talking about Jefferson and Fayette County, where most of our cases are. And a lot of our cases are involving nursing home outbreaks with spread into the community. There's an expected, based on modeling, about 3,000 deaths by December. And I think we're still probably on track for that. Now let's switch to some of the pathogenesis. We know that this virus attaches to an ACE2 receptor. These receptors are present all over. It's not only in your upper airways, but lung, GI tract, and oral tract. The virus enters your body probably by attaching to those receptors, and then its main pathophysiology is to attack the lungs. So here's a schematic looking at your alveolus, your alveolar capillary, the infection starting a inflammatory cascade, which, if not controlled, really gets out of control, leading to pulmonary edema and fibrosis of the lungs, increased activation of the coagulation pathway with microthrombus formation. And that's what we see on the pathology. So clinically, I don't think we've had a lot new. Most of it does present with a fever, chills, cough, respiratory complaints, loss of taste, loss of smell, and then a variety of other symptoms that are listed here. And then, but in terms of the overall, it hasn't really changed much from previous presentations. The incubation about the same. Most people develop symptoms, I'd say 97% develop symptoms within 11 days. The most common symptoms in hospitalized patients are fever, cough, and shortness of breath. They don't all develop simultaneously. So it is true that you can have a patient admitted without a fever and then develop a fever 1 to 2 days later. So you have to have that clinical suspicion, especially currently because we're currently in the midst of an outbreak. Loss of taste and smell, very important, probably occurs in about 30% of patients. And it's usually a 2-week illness, first week being milder, where your viral load is high, you're developing antibodies, and then into your second week, if you are controlled, there's not much of an issue. You might continue to get better. If you are not, and you have this dysregulation, you get a worsening respiratory failure. Here's pictures that people have probably seen before, but the gland grass infiltrates on CT scan. You can get rashes that look like viral exanthems, nothing really specific. Here's some examples of COVID toe. Again, remember, it's a vascular illness oftentimes, so you might get microthrombi in extremities. And then the whole aspect of children. Initially, this was called a Kawasaki-like illness. Now it's been renamed multisystem inflammatory disease for children. Remembering that Kawasaki's like illness acts like a vasculitis and with fever and has some clinical criteria: conjunctivitis, lip erythema, rash, swelling, lymph node swelling, et cetera. And a lot of this stuff was initially recognized in the beginning of the outbreak. But again, as you get, and this occurs, by the way, with symptoms as well, as you get publicity, it's not like the illness was not existent here in the beginning of March. It probably was existent from the beginning of December. It's just a recognition issue. So as you get publicity, which they started to get news reports around March 15th, here's the outbreak curve. You started to have increase in these cases of inflammatory syndrome in children going up. I don't think that the illness changed. It was there. It's just more of a recognition. Same thing for looking at some of your symptom studies, because if you look at symptom studies, a lot of times early symptoms focused and lost a lot of the taste and smell, for example, or GI components. So they've really focused on what the clinical case definition, which was used for epi purposes, focusing on fever, chills, and shortness of breath as the main clinical syndrome. And remember that when we started this whole outbreak, we had forms printed saying that you had to be from Wuhan, had exposure to Wuhan, had to have these 3 clinical symptoms. And so when you gather all the symptoms, you say, well, everybody just has these 3 symptoms and they're all from Wuhan. We kind of missed it. So, and sometimes that's an issue, confusing a case syndrome, which we're using as a case to have epi studies, with the clinical disease. So as you publicize these symptoms, when you do further studies of symptoms and report them in the literature, all of a sudden people have more taste and smell abnormalities, GI abnormalities, and you can document that based on the date of the article. So it'll still take us probably a year or 2 to sort through some of this stuff and have more robust data to say what it really looks like clinically. So to summarize the clinical stuff, it's a viral syndrome. Most of the time, you might have a normal white cell count. You might have some lymphopenia. Most people are mildly ill. And this stuff holds true. Now, this was the very beginning. We talked about this, but it hasn't really changed much. The majority of people are mildly ill. There's a smaller percentage, maybe 10 to 15% with more severe illness, and critically ill, 5% or less. In Kentucky, I think we have something like 3% ending up in the ICU. And over time, this may also change. So when we're reporting it, because we're treating the illness differently as well, we have more therapeutic options. We're not seeing as many people now ending up in the ICU. For most people, as I mentioned, it's a 2-week illness, but longer illness for those that are severe. Although we'll get into this long COVID syndrome, now they're describing, as we get longer into the outbreak, that there are people with prolonged symptoms of COVID, which are important, especially for primary care practitioners to remember. Severe disease, the cause of death in most people is a organ failure, ARDS, thromboembolic disease, multi-organ thrombosis, sepsis. We look at autopsy data, which show us that we have, in people that were not suspected to have DVTs, maybe 60% of them end up having DVTs on autopsy. You can find virus in a lot of organs, and in a recent NYU study, they had evidence of multi-organ thrombosis in multiple organs, so lungs, heart, kidneys, liver. They did not find a significant amount of myocarditis, though the myocarditis has been mentioned as one of the issues with COVID. So 20 to 43% of ICU patients might have a DVT and a PE in some series. So this also helps us think about what we might do in terms of treatment, and because we know there are increased risk for this. We can't still predict who gets severe disease with any high degree of certainty, but we have some signals. If you come in with already respiratory failure, high respiratory rate, severe lymphopenia, really high CRP, a really high ferritin, elevated LDH, those people tend to be at higher risk, or high D-dimers. There is an online calculator that's just been added. Here's one with the address here, which tries to help you looking at using artificial intelligence and using an AI, putting in your factors, and usually your factors include D-dimers and CRPs and all the different factors that you put into that calculator, and it gives you a percentage potential risk for developing severe disease. It's a model based on, and this is oftentimes what we do with modeling, we look at a data set of X number of 100 patients or 1,000 patients or whatever the size may be, and then apply it prospectively to try to see how accurate it predicts who gets severely ill. Looking at, summarizing some of the way we look at the clinical illness, then we had initial viral illness in the beginning, and then over time you can get into the severe illness where really your virus is going down, but your body's immune system has become hyperactive with positive feedback loops, which lead to worsening organ failure and eventually death. So looking at that, we're monitoring clinically, we do routine monitoring, vital signs, laboratories, and we generally try to limit the amount of radiographic studies we're doing unless they're clinically indicated, because we're trying to decrease exposure. We're trying to shorten the length of stay for all patients and considering discharge with telemedicine follow-up. Choosing medicines that decrease the exposure of the healthcare personnel. So decreasing, if you can give something once a day instead of 3 times a day, that's what you would choose. Supportive care with oxygen, especially as you progress, you might need a ventilator. Now, initially, because of the Italian outbreak, we were worried that we might run out of ventilators. And so there was a lot of work being done on how do you ration ventilators? How do you increase production of ventilators? That really hasn't come to pass for the majority of the country. And that's thankfully because of therapeutics and getting to these patients earlier and the preventative measures that we've done. Because remember, the flattening the curve was part of the issue in terms of not running out of resources with ICUs and stuff. So masking and social distancing and some of those social things really led to our ability to not run into this problem when we're running out of ventilators. We're doing more proning. We're really getting to patients beforehand. We recognize that some of those patients may still need ventilators, and there are some guidelines out there for helping us use ventilators correctly. A lot of patients, I would say the majority, if you're sick, especially if you're in the ICU, the majority of those patients, probably 90%, end up getting additional antibiotics, but still the rate of true bacterial infection is low, probably 5% or less. But the longer you stay in the ICU, again, you're more at risk for hospital-acquired infections. So we know that if you're severe, that thromboembolic disease was important. So how do we address anticoagulation? So there's a couple of different lines of thought that have to come together. There's the whole COVID line that says, okay, we have an increased risk. We can see that severity of illness is related to D-dimers. A lot of patients on autopsies have unrecognized DVTs and PEs. So what do we do with that data? And then we also have a lot of robust data from previous hospitalized patient data showing that an acutely ill patient, medically ill patient, has an increased risk for thromboembolic disease. So we have to take a lot of those different lines of evidence and try to put them together with a recognition at the same time that we don't want to cause harm to patients. So we have to pay attention to bleeding risk. So hospital systems are trying to fashion guidelines to address this issue. So non-COVID clinical trials have shown a benefit for high-risk patients based on age, usually over 60, comorbidities such as having cancer, surgery, or trauma, and elevated D-dimers, and giving those patients some kind of anticoagulation, certainly prophylactic anticoagulation for preventing DVT. And then when it comes to COVID patients, there are different sets of guidelines. You know, the American Society of Hematology, the Society of Critical Care Medicine, CHEST put out a recommendation, the NIH, the IDSA, lots of different acronyms of different groups putting out slightly different recommendations. But how can you boil that down into recommendations for this purposes of this talk? I would say that anybody that's sick to begin with COVID, for the most part, is not an asymptomatic without respiratory failure. Those patients really probably aren't admitted. They're going to be at home. So anybody that's sick and has respiratory failure probably needs to receive routine prophylaxis, not full anticoagulation, but routine prophylaxis to prevent DVT. When it comes to some of the controversies, it's more what to do with extending that going home. And so looking at the current literature, the way it states, first of all, understand that different places are doing different things. So if I look at this with up to date and I go to the different guidelines from Mass General all the way to the University of Washington, everybody's doing slightly different things. If I look at the major organizations like NIH, they have different recommendations, basically not recommending any of these things to be done, but to participate in a routine clinical trial, because there are clinical trials going on trying to figure out the risk benefit. Are patients going to benefit if we send them out of the hospital on prophylaxis? So there are not enough data to give you a blanket recommendation that those patients need to go in. But there are signals saying that potentially somebody who is critically ill in the hospital and looking at their risk factors that would already have put them in a high risk for developing thromboembolic disease, that they may benefit from receiving some type of prophylactic anticoagulation when they get discharged. And the duration of that anticoagulation is still unclear. Should it be 2 weeks? Should it be 4 weeks? And should it be with Lovenox? Should it be with Xarelto? All that kind of stuff is still being worked out. And there has to be some type of system-wide, whether it's in the Baptist system or the St. Joe system, whatever system you're working with, agreement on documentation. First of all, we got to document that the patient's at increased risk, and you can use that with some of those scores. Like the previous slide had the improv score, which tries to balance those risk factors that I've mentioned. Are they increased age, immobile, and have other evidence of having a risk for DVT, such as high D dimers? Those patients may benefit from a course of prophylactic anticoagulation. So when we look at treatment, there are almost 2,000 trials right now for treatment for COVID. That's a lot of treatment. And we have to take that in the context that we are faced with taking care of sick patients and waiting for clinical trial data to catch up to the fact that we still have patients in the hospital, and some of them are doing poorly. And so how do we balance the two? It's not easy to do that. But we do have to have some kind of a balance between doing nothing and waiting for clinical trial data and doing something for patients, especially if they're critically ill. At this point, on the 14th of August, here's the treatment algorithm that we look at and what's the basis of it. Steroids are beneficial in the treatment of COVID. Initially, we had some caution about that because previous outbreaks with SARS had mentioned that steroids might prolong viral excretion, and so that was not thought to be potentially beneficial. But new data from clinical trials has shown us that that's probably beneficial. Remember, there's no approved treatment, but after steroids, additional data supports the use of remdesivir in convalescent plasma. And you notice that hydroxychloroquine is not part of this at this point, because more data has come in and has kind of pushed hydroxychloroquine just to the clinical trial status. And when talking about vaccines, there's 29 vaccine trials going on right now. So the first steroid data was looking at steroids in recovery. The recovery trial, which looked at over 2,000 patients, looking at Decadron for 10 days versus usual care, 4,000 patients with usual care. And it showed a decrease in mortality by 28 days, especially in those patients that were ventilated and those with oxygen requirements. So the biggest success was showing that in patients that were ventilated and more severely ill had quite a bit of difference in their outcome, 29% mortality versus 41%. If you had oxygen, you still had a statistically significant benefit, 23 versus 26%. But if you didn't need oxygen, you didn't have much of a benefit. So that again starts to give us a treatment paradigm. If you're in the hospital and you require oxygen, you're considered to have essentially severe disease by these clinical criteria, whether it's using CDC's criteria or these clinical trial criteria. And those patients should be considered treated with a Decadron. Now, at one point, Decadron was also not available for some systems, but you can use other equivalents. So I'm just putting down one, prednisone, but you can use hydroxychloroquine or methylprednisolone equivalents to try to treat those patients. Remdesivir also, which was initially, remember, developed for Ebola, has been looked at, and initial data had some small trials saying that 5 days was equivalent to 10 days, which gets us to how we're using it currently. And then when you looked at their clinical trial, double-blind randomized trial, that you did have not a major improvement in terms of mortality, but at least an improvement in recovery. So 11 days versus 15 days in placebo. And it gave us another glimmer that this is a medicine to use. And their criteria was also respiratory failure. So those that have an oxygen requirement should probably get remdesivir. So here's again, it helps with our treatment paradigm. Respiratory failure, admission to a hospital with COVID should be considered for steroids and remdesivir. If you're not on oxygen, you shouldn't really be getting steroids and remdesivir. So that really makes it's not that complicated. I think it helps us figure those treatment algorithms. And in terms of hospital systems, figuring that out in our, whether it's pharmacy algorithms with our hospitalists or intensivists, that is a good way to set that up. Convalescent plasma is still an ongoing saga. We used data previously from other outbreaks and meta-analysis to say that it has been useful in the past, and using it earlier was important than using it later. The data are still small in terms of published trials. Initially, we're talking about 5 people treated here, 10 people treated there, with positive results. We did have some clinical improvement in patients, and so that was hopeful. But we still have data. There's a data deficit. So in published trials, 103 people published in China using convalescent plasma. It was underpowered, didn't show much of a difference. But here's a non-peer-reviewed MEDRIX. Remember, that's the preprint server. In 800 patients showed a benefit, 13% mortality amongst those receiving convalescent plasma versus 25%. Very difficult to look at some of these studies because they're really not very well controlled. So a lot of times what you're looking at is patients not only are receiving convalescent plasma, they're receiving a ton of other medications, which may include remdesivir, it may include, steroids, it may include other things that influence the result, but that's just the status of what's happening. Tocilizumab, remember the early stages of disease are a viral illness, where we're talking about using steroids maybe to blunt the inflammatory response, remdesivir to deal with the virus itself. And then if things don't work and you progress, you get into this hyperimmune syndrome. And it's in that point that we have personally used some of these medications that are against IL-6, which is a cytokine that basically is a marker for the inflammatory process getting out of control. It's an anti-IL-6 treatment. And we've had personal saying, we've had small numbers that we've used here. At Baptist, we've used it in probably over 20 patients, personally using it in a number of patients. And we've had good success with patients really turning off that inflammatory response. So after we gave the medication, they became afebrile. They eventually, majority of those patients ended up off the ventilator and walked out of the hospital. That is personally, but the difficult thing to do is to use that. One of the things we used to teach residents that what are the 3 most dangerous words in medicine, in my experience. So you got to be careful about using that as the basis for just general recommendations. So we got to look to clinical trials. But again, we're trying to balance, terribly sick patients with what is available clinically. So clinical data at this point with 400 patients, and this is unpublished data, says that maybe there's not much of a difference in severe COVID pneumonia. Now, the problem is how are we using these medications? If, for example, I'm using, and we don't have the data to break this down, so it's difficult to understand. If I'm using a medicine like tocilizumab, and I'm saying severe, and severe just means that you're on 3 liters of oxygen, and when you get into the hospital, that's not the same patient to me as somebody who's having a temperature who's also severe. somebody who is having a temperature in the ICU on the ventilator with a temperature of 103, whose CRP and IL-6 and everything else is crazily high, and they're in a cytokine storm. That's a different patient where they all might be lumped together as severe COVID. So it really kind of depends on what illness that you're treating. We are tending to think now that these IL-6 type agents might need to be treated in the cytokine storm where patients are much more severely ill than just earlier on. But there's been discussion, and as the outbreak has gone along, and we've discussed this with people that are treating patients at institutions such as Yale, UK, different institutions, trying to figure out, is there a sweet spot to use some of these medications? That data hasn't been correlated. The Yale study, which looked at 239 patients, said that there was probably some benefit. And the survival rate on those patients that ended up on a ventilator was 75%. And that is significantly better than the typical survival rate that was reported at the time. So it's a work in progress. I think we're still working on trying to fine tune this, probably to having more strict criteria where they're clinically unstable in the ICU, persistently high fevers, and we can choose what that fever level will be, where they're basically dying, despite receiving, aggressive other therapies that we have used, such as the steroids, remdesivir, convalescent plasma. But that's more to follow. So to summarize our treatment aspects, it's at the beginning using Decadron and remdesivir, especially if they have respiratory failure, moving on toward convalescent plasma if they're continuing to be ill, and then looking at the immune system treatments such as tocilizumab if they're really in cytokine storm. And that's where we are with our current treatment paradigm. So we get the patient well, then we discharge them. Primary care has to be aware that there is such a thing being described more and more as long COVID. Long COVID meaning in maybe almost 90% of your patients that we discharge from hospital, if you do a clear questionnaire about how they're doing, report a symptom 2 months after being discharged. That's pretty significant. Now, the most common symptom is fatigue, but a lot of these also include things like short of breath. Now, they might have a normal O2 saturation, but somehow they're having some kind of shortness of breath going on. And it may be because there is some microvascular disease going on in their lungs that we just can't detect objectively, but does affect how they do. So on the right-hand side, it's probably too small to really see on a projection, but the references here in the British Medical Journal reported in the last month, a kind of a nice paradigm to think about how to look at that patient and what to do for them in the long haul. Moving on to prevention, where do we stand? How are we protecting patients and healthcare workers? We have had these change over time because remember, as we get more data and we learn the importance of masking, or we learn the importance of testing or testing our pre-op patients, we start to change some of our processes. So where do we stand right now? We still have a process for evaluating patients, including pre-op screening of patients before, and we do have positives of asymptomatic positives before they get into the hospital, which is great. At least we find these patients before putting them in to the hospital, doing procedures and causing some transmission within the hospital to healthcare workers. We are still isolating and protecting healthcare personnel using PPE, engineering controls, and administrative controls. We've varied with our administrative controls, so now we're relaxing some of the visitor recommendations as we get more of a handle on the outbreak. We can show with data that masking has had some effect. If you look at the Mass General, looking at their institution of masking guidelines for their healthcare workers, this is the rate of infection that was going on in healthcare workers and then over time, as they had universal masking for patients and healthcare workers, they showed a decrease in the rate of positivity amongst healthcare workers. So masking has some effect. We already know that that's important, but it's a relatively simple thing. It's annoying, I'm sure. It annoys me to wear a mask all the time, but it does have a positive benefit, and it's low tech. It's like there's no side effect to that, except for maybe, sometimes I get a little eczema on my face, but other than that, really low tech and does work. So we've had some discussion about the changes. There are some changes in who gets isolated. And remember, initially on, we didn't know what to make of a PCR. Anybody that had a positive PCR, even if it was 2 months later, we thought they might have active virus. We're working without complete data. But as time has gone on, we've had more and more data to put some sense and some evidence based on what we're doing with our quarantine. And there's also some misunderstanding between people thinking about quarantine and isolation, and some irritation, because I hear this sometimes. That person, I got exposed, now I'm quarantined for 14 days. That, it ticks them off that they're quarantined for 14 days. And they go, why am I quarantined? This person this person was infected and they got out in 10 days. That sucks. I understand that frustration. I mean, already we're dealing with a lot of frustration, but there is a difference in understanding about why we're doing this. So if you're quarantined, it means you're exposed and you have an incubation period. The incubation period is about 14 days. So you can develop illness in 14 days. Somebody that's infected, we know what's going to happen in general to their virus. So we can make a different recommendation. So what's going to happen to their virus? So initially, they have a live virus and we can detect it. They have a positive PCR. They have a little bit of a sore throat and a fever. But after 10 days, we can't isolate virus anymore. So that person really is not considered contagious. Awesome that we have that data now. And because we didn't have that data before, we heard bits and pieces. It's never put on a website or an article. And so it's hard to make a system recommendation. But now we have some of those recommendations. So if you go to the websites for CDC, at least cdc.gov, you can find, and they put down the discussion points and where some of that data comes from, the compilation of labs now looking at mildly ill patients, severely ill patients, and saying, how long can we detect the virus? So mildly ill patients, we don't generally detect it after 10 days. So that is a great way to say, you come in, you have a little 2 liters nasal prong, you did okay, you got better. After 10 days, we can back off worrying about your isolation. Now, if you're severely ill or if you're immunocompromised, and this, by the way, is assuming you're not febrile and you're clinically improved, okay? That's taking all that into account. If you're more severely ill, 20 days is the time period. And that is saying that after that time period, we really can't detect the virus. So coming up with those criteria, we have those non-test-based criteria based on symptoms alone, which has changed some of our practice in the hospital. We're trying to keep track of when people have symptoms, when people have a positive test. If you're asymptomatic, you're considered to have 10 days after that positive test where you don't need to be isolated. So some of that data has been very helpful and just only recently available. So we talked about this. I already talked about the time course of, now, let me touch on this. There still is not great evidence of reinfection after 6 months. So we're 6 months, at least at 6 months, there's not, but as my partners, because you always get somebody will throw you an article and say, wait a second, what about this? There may be somebody that gets reinfected at some point. We're talking about the vast majority. And that is probably based on your antibody, your immune response. Most of us develop an immune response, but not all the same. I'm not saying that's all the same, because there are data saying if you're minimally ill or asymptomatic, you might not develop the same antibody response. You might have waning immunity. Your immunity might go down quicker. But we don't know all aspects of immunity yet. So you might have, it's not only antibody immunity that we deal with, it's T-cell immunity as well. So at this point, we know that there are not a lot of cases of reinfection. Now, that doesn't mean that I could have tested negative a couple of times if I had illness, and then a month later, I feel a little bit sick, and then I have another positive PCR. You actually may excrete that RNA for a while, but the majority of those cases are not, the vast majority are not going to be reactivated disease. At this point, that's where the data stands. Here's some, again, data showing, if you look at, these are ill patients. These are severely ill patients, including transplant patients. If you see these black boxes, they are live virus. So there's a lot of viral samples. the majority of people after 20 days, basically, this is a 20-day mark, you cannot isolate the virus. These are severely ICU bound and even transplant patients. So this is comforting. The majority of the specimens here, even though you do have some positives, it's still about only, in terms of quantity, it's still only about 15% of those patients having a positive viral culture. What are we doing in the community? We still are emphasizing low tech, simple to do, but hard to enforce ways, okay? Masking, social distancing, hand hygiene, avoid touching your face. We are trying to institute policies that Governor Beshear has put in place. For example, you have to deal with closing the bars. They just renewed on August 6th another 30-day masking for the state, and quarantining if traveling to high-risk states reporting a positive rate of greater than 15 days. Trying to limit social gatherings to 10 or fewer. We're going to be trying to institute these types of things off and on, depending upon what's going on in the state. It may change, for example, in the fall, because the fall coming in with respiratory virus season and influenza, we might have more difficulty handling the load in the hospitals. We'll have to wait and see. What about other prevention? Hydroxychloroquine, at this point, with the data available, doesn't seem to be that effective. There is a University of Minnesota study published randomizing placebo to hydroxychloroquine, did not show a benefit in taking hydroxychloroquine after exposure. There's a Spanish study of over 2,000 people who randomized those exposed and didn't show much of a benefit. These are relatively recent studies in terms of their publication. Now, I got to put a caveat to it. I don't think the studies were well done overall, because it's very hard to characterize exposure. So if I was a healthcare worker and I took care of a patient, I had a mask on, the patient had a mask on, that's a different type of exposure than if I intubated a patient, nobody had any PPE on. That really wasn't well teased out between the studies. If I'm actually living with the patient and got a high amount of exposure. So exposures are difficult to control for, but at this point, there's no data supporting the use of hydroxychloroquine for prophylaxis. Vaccines are the last part of the, touch on. Remember, there's 29 vaccine trials going on, and there's this goal. Operation Warp Speed was put in place to try to have 300 million doses of a vaccine available by January 2021. The likelihood that that's going to happen is, I think it's almost not going to happen. And we do got to be careful about rushing any vaccine too soon, because we have plenty of data from previous uses of vaccines where if you roll things out too soon, you really can cause a lot of harm. Here are one of the five major contenders, and the different technologies. We're using adenovirus vaccines. This Moderna got a lot of publicity. They're currently in a phase 3 trial of 30,000 people. And it's really interesting technology because this is using an mRNA. So messenger RNA, typically this type of vaccine technology has never been used in large scales for humans. Difficult to put a messenger RNA into the body because it will get degraded. So you have to develop new technologies to deliver the messenger RNA. And what the messenger RNA is it's trying to deliver instructions to your body to produce something that looks like part of the spike protein of the virus itself, and your body can develop antibodies and an immune response to that protein production. So what did they have to do? They had to have a nanotechnology where they envelop the mRNA and allow it to be injected, and then your body develops the immune response. Now, in the phase 1 and 2 trials, they've had success with developing good immune and neutralizing antibodies to the virus. So that has been encouraging in terms of that technology. This other technologies are similar in terms of using viral vectors to deliver genetic material and have your body produce part of the protein, which allows your body to have the immune response. One big controversy that will happen also will be some of these countries, such as Johnson and Johnson's vaccine, is a single dose vaccine, which in the big picture, although they're not into a phase 3 trial, may be a real important aspect. If you can get protection with one dose versus Moderna, which needs 2 doses, that's a big deal. From a practical standpoint, if you're trying to vaccinate the world, that's a big deal, because getting people vaccinated to begin with is difficult. If you look at the vaccine acceptance rate right now, if you're looking at surveys, the vaccine acceptance rate in the United States is probably, even for COVID, is probably 50% or less. So to try to get people in twice to vaccinate them, it's going to be difficult. But that is a key part to moving forward in terms of the handling this, therapeutics, prevention aspects in terms of our social measures, masking, social distancing, hygiene, prevention in terms of vaccines and therapeutics. All those things are needed to really get control of this and to open up the country to have a more normal life. So hopefully that will be happening. Lastly, there's always going to be controversies. This is it's been relentless, and it just seems to continue to go on. Unfortunately, it didn't go away in the summer. It's still here. There's always going to be risk-benefit discussions about what we do with our public health measures and the amount of disease burden and the downside of it. We know businesses have been closed, unemployment has been affected, other illnesses have been affected, whether it's the opiate epidemic, the not getting appropriate cancer care, whatever the thing may be. We know those things are being affected. But trying to balance that with the benefit of managing so that we don't get overwhelmed in local hospitals, and people are arguing both ways. It's becoming a fairly political football between the conservatives, Republicans, libertarians, et cetera, Democrats and Republicans. Of course, this is occurring in the setting of an election. So everybody is getting, in November, getting their different spin on what they think is important. But we're trying to use the best data going forward, trying to have evidence-based, procedures to go forward. There's been a mention, well, this is, more people are, getting affected by car accidents and, deaths from a car or not using a seatbelt. Well, this isn't a seatbelt issue. This is a contagious disease, and we're still trying to manage it. It's still a new disease. So I don't think some of the corollaries looking at the effect of car accidents is the same as looking at an infectious disease. So the level of measures also being taken, there's not always a clear-cut national solution and perfect gold standard, because it isn't occurring the same in every community. And so that leads to some confusion. And then, of course, things have changed over time, and that's based on more information that comes in over time, and then are trying to apply that to something that's as common sense as we can make it. This also occurs in the setting of we're getting stressed out. Everybody's stressed out. The burdens of the epidemic, what it's doing to our personal life, the upcoming school year, what are we going to do with childcare? What are we going to do with our kids? A lot of those aren't clear-cut answers. That's just the reality of it. And people are trying to fashion some kind of way to work that out. There are a lot of people behind the scenes working on that besides yourself. You have your own family structure working on that. There are other people, and all the employers are trying to think about what's going to happen and trying to figure out whether it's a hospital system, how are we going to work with trying to provide a good, safe environment for our patients, our family, dealing with workplace issues that may occur when people get sick and when schools open back up. Remember to be kind to each other, because it's just going to be hard, and it's still continuing. And we have to take a step back, do something that helps take care of yourself, physically, spiritually, emotionally. Be kind to other people. That helps us get through a difficult time. And we will endure through this. It'll continue to get better. Don't expect the government will not save you. The hospital will not. And we have to work on this together. It takes a lot of people together to make this work out. Can there be improvement in communication to messaging, whether it's at the top level in the government or the bottom level, if you're an employer? Of course there can be. And if you find areas that the hospital system needs to improve on in terms of its messaging or giving you guidance, please get back to us to tell us how we can do and make things better. Because there are a million facets to what goes on when you talk about this type of occurrence. There's nobody that's going to be an expert on everything. So we need your help to make it better. And with that, I will end my presentation. I appreciate your attention. Thank you. So if there's any questions, I guess we can take them in some fashion on this. Should I close this? I don't see anything popping up. Patrick? Oh, I can't see it on my screen. Let's see. Should I just minimize this and see it or something, or what? Yeah, I can't see it on my screen. So you see it on your screen. I don't see it on my screen. What's the question? Well, what? Okay, here's what I think was going to happen with quarantine measures. Now, this is me. Now, I don't want to get in trouble, but there are caveats written into the CDC guidelines. We are going to have a difficult time with exposures as things ramp up and in the cold and flu season, because when you open up schools and when the incidence of viral illnesses increases in the fall, there are going to be a lot of people that have more difficult choices in terms of exposures. And there is a caveat that if we run out of healthcare workers that will be doing a lot of self-monitoring, remember, one of the things that we will be doing in the workplace, and we're probably going to continue into the fall, is masking and enhanced infection control measures. So I think that will be important in terms of preventing. We don't want to transmit it to each other or transmit it to our patients. But as if you typically, as it stands, if you get exposed, you have a 14-day quarantine. But if everything becomes overwhelming and we run out of staff, we might have to do more self-monitoring in the workplace with masking and enhanced infection control. But that'll be determined on a case-by-case basis, and probably on a system basis, based on workforce needs. Antigen testing still the gold standard for testing is going to be PCR. Antigen testing is still it's still in its early stages in terms of its role in looking at where it stands, and there's a lot of operator dependence on antigen testing. So I think that we'll need to see that going forward. I think its role in the antibody testing, so serologic testing, is it's still, we're rolling it out for purposes of surveillance. I think it's important for purposes of saying you're not ever going to be contagious, or that you are truly protected. At this point in August 2020, we don't have that information, so I don't think we have great correlation between saying, because you have a positive IgG, that you're going to have protection for disease. And also remember that the operating characteristics of all the serologic tests depend on prevalence. So you're likely, if you have a good serologic test, but you have a very low prevalence of disease, say 2%, that you're also likely to have a false positive serologic test. So it really depends on what's going on. Over time, I think we will be using these tests if we have a better idea. But remember, I think that serologic tests are also one point in time. It's likely that that your antibody response declines over time. We don't know when that information is. We have some some insight in small groups that if you're not that sick, your serologic response may decline in a couple of months. If you're really sick, it declines a lot slower. And if we look at previous SARS outbreaks, which is another virus, you can detect antibody for a year or two. We don't know whether that correlates with protection. But if we're looking at previous coronavirus infections, we know that you can get reinfected with coronavirus. So it's generally not the same thing, again, as a measles virus where you get infected and you have lifelong immunity. You get infected, you can get infected in the future, but we don't know that time period. It may be a year, it may be 2 years, but it may be at some point, which when we look at vaccination strategies, that begs the question that we may need to have revaccination campaigns like we do with influenza, so that you may have periods of time where you have to get your COVID and your influenza vaccination in order to maintain some immunity. And that, I don't know how often that may be. It may be annual or it might be different time period, but that's something to be determined.
What about the patient who needs elective surgery and is admitted to the hospital and has been there for a few days?
In general, they don't. I don't think they do need to be screened. Now, I would say it also depends on where they come from. Now, if they come from a known area that has a high risk, that has an ongoing outbreak, say they're we won't mention the name of the nursing home, a nursing home that is having an active outbreak, that might be on a case-by-case basis. So you really do got to think about the risk. The likelihood for a typical patient is that they do not need to be reinfected. But if they're coming in because they have an acute perf divertic, and they're coming in from a nursing home as an active outbreak with a lot of cases, and they have one negative test, we may still screen them if they get surgery 2 days later. That's something to be discussed. But for the vast majority of patients, no.
Another question about
I don't know. I don't know. It's one of the 14,000 articles I did not see, and I don't know. All right. Well, thank you for your attention. And this meeting is concluded.